Welcome to the Mountain West AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to our speaker for the talk today.
Hi everyone, very nice to meet you. I wanted to talk a little bit about the MAX Clinic, which is a new pilot program that was started by Dr. Julie Dombrowski and Dr. Matt Golden in conjunction with the STD Clinic and the Madison Clinic to really engage those patients who are hardest to reach. And I know all of us have these types of patients in our clinics, and we wonder what we can do about it. This is an opportune time to speak because recently a JAMA article in July, I think, of this year just came out saying that financial incentives don't work to engage persons with a detectable viral load. And I think it's important to kind of look at different models, and this is the model that we've come up with, and so far I think it's working. So I just wanted to take a minute to describe what the MAX Clinic is, and then also describe what I find as a provider has really worked for us that could be used for your particular situation in the community. So I'm just going to go a little bit over the background, why this was started, what is the MAX Clinic, the outcomes that we have seen so far. It's been about a year and a half. And then what aspects of the MAX Clinic are applicable to community-based practices. And feel free if you guys have any questions. So I'm sure you guys have all seen this. This is the HIV care cascade. This is the 2011 one, the HIV care continuum that's posted on the CDC website. I think the numbers are a little bit better now, but still they're pretty dismal in terms of HIV patients who are diagnosed and then virally suppressed. The numbers are not that great, and there is a proportion of patients that we would like to get virally suppressed, one for their own benefit and then also for a public health reason. So this is a little bit better. This is actually the Washington State HIV care cascade, and as you can see here, so of the patients who are living with HIV and AIDS in Washington State, 68%, so quite a substantial portion more, are actually not only engaged in care but virally suppressed. So background. So there's a lack of evidence to guide HIV care re-engagement. Communities have tried counseling, navigation, referral to support services, contingency management, but there's very few controlled studies. Most of these interventions attempt to re-engage patients in the same actual HIV care system from which they disengaged in the first place. So one of the questions was, can we change the structure of care available to these patients in a way that would be applicable to exactly their lifestyle and behavior? So the patient recruitment came from all different sources, but the eligibility criteria was patients who had a viral load of greater than 1,000 copies or no viral load for greater than 12 months and off of antiretroviral therapy. And that's important because there are some patients who don't come into clinic, but they take their meds all the time. And that's not necessarily the patients that we wanted to start out with right away. And then also a failure to re-engage in care with public health and clinical outreach assistance, which has already been demonstrated in the STD clinic already. We've been doing a lot of outreach programs. And then the routes of identification was public health relinkage and partner service activities through medical providers, case managers, navigators, through the jail, and then peer referrals as well. We've had patients who come in with a friend who's been out of care for about 7 years and someone who's never really been in the system. So you have this identification of potential MAX patients, and through that we have disease intervention specialists who are fantastic, and they do a lot of intensive support and outreach. They provide a single point of contact to actually access these patients and providers, and through calls, text messages, meeting patients in hospital, clinics, homes, or even jail, they'll actually talk to them about the MAX Clinic and invite them to come in. So the enrollment of patients happens, and then we provide quite a few services. We do walk-in medical care, and that's really important for patients who have a lot of issues with appointments, and that's one of the reasons why they've had problems engaging in care. And that's 5 afternoons per week in the STD clinic, so actually physically away from the Madison Clinic where they previously had engaged before. They get snacks and meal vouchers each visit up to once weekly. And then cell phones are provided with service, and then bus passage based on contingent renewal. So they have to continue to engage for those to be renewed. And then they get cash incentives. So every 2 months, they get $25 for a visit with a provider, as well as a lab draw, and then $100 for suppressed viral load. Plus, if they get 3 in a row, they get one extra $100 as a bonus. So from January to December, we had 50 patients. And you can see here just like a little table that shows that about 46% of them came from a provider case manager referral source. 46 were through public health outreach programs. We get laboratory data of all the positive HIV patients in the state, and we kind of track those down and see if they're engaged in care. And then also peer referrals was about 8%. Most of these patients had viral loads, CD4 counts less than 200. They all had detectable viral loads. And the majority, 88% of them, had illicit stimulant or opiate use, with a majority also of unstable housing, and then 1/3 had a Hep C co-infection. So this is a nice graph to kind of show our HIV care continuum outcomes for those 50 patients that were analyzed at the 5-month mark and then the 9-month mark after enrolling in the Max Clinic. So as you can see, of the patients here that were enrolled, by the 5-month mark, about 58% had achieved viral load suppression. And that's a big deal. These are patients who had never really been suppressed before. So 58% is actually quite a big deal. And then by the 9-month mark, we want to see if the sustainability of this. You can see here that 74% had actually achieved viral load suppression at least one period of time. And that's important to realize as well, because that's a public health impact too. A lot of these patients are very high risk. They're sharing needles, or they're having a lot of sexual partners. And so even just achieving that viral load suppression for a short period of time is a big deal. And then 56% of these 50 patients that we carefully analyzed so far had a viral load suppression at the last visit. This is a nice kind of little simple table that I like to look at of the patients that have enrolled in purple from September, February, and June, the number that were suppressed in the blue for those dates, and then the percentage of those that are enrolled that are suppressed are here in black. And so far, actually up to now, we kind of just really increased enrollment. So we have about 75 to 80 patients now, and about 54% are still unsuppressed. So what have I found that can be applied in the community? I think the main thing to remember is that you don't need the same intervention for everyone, and it depends on the patient population. Even though we've gotten 54% suppression, it's still only 54% suppression. Even what we're doing doesn't work for everyone. And I think it depends on the patient population that you might necessarily have and what makeup these types of patients are, and how do you reach out to what they might need. So in some instances, I've had patients say, I need housing, and if I get housing, I will get suppressed. And I'm not kidding. As soon as I get them housing, they get suppressed. Substance abuse is also a major issue. Uncontrolled mental health issues is also another thing, and then all of the above, which is a lot of my patient population. So what have I found? So I find that for my patients who are homeless, asking the pharmacy or some other way to actually dose their meds every weekly or every 2 weeks is really important for them, because they lose their meds often, or their stuff gets stolen. And so because of insurance issues, they can only get the 30-day supply. And so then you're kind of dealing with that kind of barriers. In Seattle, at least, a couple of the buildings that have low-income housing will have a case manager or social worker, even front desk, that will give them their meds every day, and that has worked really well for some patients who are housed in those areas. So that's been a great kind of source. Our pharmacy, for a couple patients, and they've been really great about this, will do little bubble packs, and we'll hold the bubble packs and give them to them weekly when they come for their food vouchers, which has been working really well. Hiring a case manager, I've seen this in other communities. For us, these patients have disengaged, and a lot of them have a very big distrust of the medical system. And so having one source of contact that they can always kind of rely on, someone who they feel is in their boat, someone who's advocating for them, makes a huge difference. I talked to a nurse case manager actually out in Michigan, where their community actually hired a nurse case manager because a lot of their patients were housed in that particular community. So she would go out to their homes and actually do some blood draws that they needed, or medical management of medications. And that was really useful for getting a certain patient population there that couldn't come in always to make an appointment. Drop-in features has been really great, and I know not everybody can do this. We have 3 main HIV providers who do our clinic, and it's hard on the providers. These patients have been out of care for 7 years, are very complicated, but you get to know them over time. And I think, if you make 1 or 2 goals your main goal, then you can kind of stretch it out from there. And it's been really wonderful, our help with the Madison Clinic, because our mental health providers there also offered on certain days to do drop-in for psychiatry and psychology visits, which has been fantastic. So I know not everybody can do drop-in, but one consideration is to make half a day a week drop-in for the hard to engage patients, or to reserve like 1 or 2 appointments half a day a week for patients who might come in, just as you would triage. We have found incentives do work. For certain patients, they say, why should I get on meds? And I'll go through the whole, rhythm and roll, and they say, well, that's not good enough for me. And I said, well, you'll get $100. Well, that's good enough for me. And it's worked for those particular people. And then, there's always the risks and benefits of starting treatment immediately. I feel like in this patient population, starting treatment immediately has been very helpful. Not necessarily making them go through a whole process where they have to make 4 or 5 different appointments. They just can't do that. And our pharmacy has also been really fantastic, because our clinical pharmacists will do kind of like drop-in kind of counseling with them as well. And these patients will actually go across the street to Madison Clinic for a lot of that. And then lastly, and I don't know how savvy your tech support is, but we actually developed a text messaging system through Epic, and it's all patient confidential, so like there's no PHI that's being distributed. But basically, in order to find patients, we realized it was really difficult because they're homeless and they don't have a phone. How do you go out and find out where these patients are? So we realized a lot of these patients, because they're so sick, a lot of times end up in the hospital. And so if we could tag onto that, that would be great. And so our case managers and our DIS officers will get a text message when one of the patients that we have outlined that we're looking for shows up in the ER or in the hospital, and then we'll go and reach out to them that way. And that has actually really increased our enrollment for the clinic. So that's all I had to say. I just wanted to thank, of course, Julie and Matt, and then Allison, Rachel, Mark, and Angela are our DIS officers and non-medical case managers, and then Sharisa and Bob Harrington, of course, at the Madison Clinic, and then Dawn also, who's one of our DIS officers, and then, of course, the Madison staff has been really wonderful in making this clinic such a success, and I think we're just going to see how it goes and how sustainable this is.